Well, the title which was given to me is Recent Advance of Diagnosis and the Treatment for the Systemic Lupus Erythematosus. Well, first of all, I'd like to talk about the diagnosis for the systemic lupus erythematosus. This slide shows that the survival rate of a SLE patient in these 50 years in Jude, John Danaher University database of erythematosus. The number of patients is 2,390. Then a 10-year survival of the lupus patient, well, shown here, it was about 60% between 1955 to 1975. But the discovery of these specific autoantibodies and the diagnostic criteria using them contributed to the early diagnosis followed by the prompt and aggressive treatment. The rate went up to over 95% in these 35 years. Well, this is a slide of the 1997 diverse criteria, which was proposed by the ACR. Well, original, this criteria was proposed by Professor Entan. He's my mentor, originally from Malaysia. And then this criteria was revised in 1997. According to the revision, the item positive array preparation was deleted, and the criteria for the autoimmunological disorders were changed to include anti-cardiolipin antibodies. So utilizing the autoantibodies, which is quite a specific group, such as double-stranded DNA or as anti-SM, well, this criteria had a higher sensitivity comparing with the previous diagnostic criteria, and it became possible to diagnose the patient with having the lupus in early stage. Well, then, of course, it contributes to that prompt and treating. But there are several problems. Maybe I must say a few problems. For example, although the patient has a complete historical feature of the lupus nephritis and have antibodies to the double-strand DNA, of course positive for ANA, if this patient do not have any other items out of 11, then this patient cannot be diagnosed as having lupus. The other problem is, in fact, if patient had a photosensitivity, oral ulcer, maybe slight arthritis, plus, for example, leukopenia. Well, this patient could be diagnosed as having lupus without any characteristic serological feature, such as anti-nuclear antibody positive or anti-double-strand DNA. So sometimes patients with Sjogren's syndrome could be diagnosed as having lupus. This was a problem. Then concerning such problems, Systemic Lupus International Collaborating Clinics try to develop the new criteria as shown here. This criteria has a characteristic feature because those criteria was divided into two parts. One is the clinical criteria, the other is the immunological criteria. Then if we look at this clinical criteria, okay, this is a very good news for the dermatologist. A previous one has just a malar rash and photosensitivity. They have just only two items in that out of 11 criterion. But well, this time the rash was divided into the two parts. One is acute cutaneous lupus, and the other is a chronic cutaneous lupus. Well, then the acute cutaneous lupus involves lupus malar rash plus lupus toxic epidermal necrolysis variant of SLE, maculopapular lupus rash, and the photosensitive lupus rash and subcutaneous lupus. Okay, so nowadays, this criteria has a variety of the skin manifestation. Then if we look at the chronic cutaneous lupus, well, it involves the classic discoid rash, hypertrophic lupus, and lupus panniculitis, and mucosal lupus, and lupus erythematosus timidus, and children lupus, and also the discoid lupus, and IgN that planus overlapped. So therefore, now that this criteria has a variety of skin manifestations, that gave us a headache for the dermatologist, but maybe good news for the dermatologist. And then used to be Hemolytic anemia and the leukopenia, lymphopenia, and the thrombocytopenia was included in only one items, hematological disorders. But in this new criteria, it was treated as independent items as shown here. Then if we look at the immunological criteria, well, newly at low serum level of complement and the direct Coombs test was added as the immunological disorder, which is specific for the lupus patient. Then, to be diagnosed as having lupus, the patient must satisfy at least 4 criteria, including at least 1 criterion and 1 immunological clinical criterion and 1 immunological criterion. So without immunological disorder, our patient could not be diagnosed as having that lupus. But there is an exception. If patient has a quite typical, biopsy proven the lupus nephritis and positive for ANA and double-strand DNA, then although this patient had just only 3 items, but could be diagnosed as having lupus. Okay. Then, if compare the sensitivity and the specificity of this new criteria with that previous one, if they use their own group of patients, as you can see here, strict criteria sensitivity was 19.4 versus that previous one in that 86. And if talk about the specificity, well, that the specificity of strict is 19.2 and the previous one 93. So as you can realize here, the new criteria proposed by strict had a higher sensitivity, but a little bit lower specificity. But if they use a different group of patients, it was shown that the sensitivity goes up to 97%, and that it was 83% in the previous one, and the specificity 84 versus 96. Well, so this result also shows that the higher sensitivity of the strict, but lower specificity. Okay. So right now, it was proposed in the 2012, about 3 years ago. But still, we are using the previous criteria in the daily clinic. I don't know. We still have to check whether which one is better. But maybe it is possible that this criteria will be utilized firstly in the drug trial. But we got to see which is better. Right now, I don't have exact answer. Anyway, if we use this criteria, sensitivity will increase. Okay. Then I want to talk about the new approach to treat the patient with lupus. I want to talk about the efficacy and safety of so many different types of drug. Again, as I mentioned before, this is the survival rate actually improved in these 35 years. But as you people know that still many lupus patients have that so-called intractable involvement shown as this slide. Well, lupus nephritis and the neuropsychiatric SLE, NPSLE, idiopathic thrombocytopenic purpura, and autoimmune hemolytic anemia, acute lupus pneumonitis or pulmonary hemorrhage, and pulmonary hypertension, catastrophic antiphospholipid antibody syndrome, and even adverse reaction of steroids sometimes gave serious problem to the lupus patients, So these involvement sometimes causes future outcome. Among those, I think that the most important issue is actually this lupus nephritis. So that's I want to talk about the treatment, how to treat the lupus nephritis, mainly today. Okay. Then this slide shows the past and recent cause of this in 37 monotype cases of June. Then before 1984, number 1 cause of this was uremia. It was at 37.5%. But after that, until that almost the 2002 year, well, the cause of this as the uremia goes down to that actually that 6.3%. So it's look like uremia or renal involvement is not a real problem. But actually, if we see that the pathological finding in autopsies, the 73 patient, as you can see that the lupus nephritis was observed in almost all patients, 95% of patients, so that the most of patients had renal involvement and were treated with a large amount of corticosteroid and immunosuppressive drug. Then that caused a serious infection. Some people are dying, patients are dying because of infection. So I must say that the lupus nephritis is still an important factor to determine the fate of the patient. Well, then this slide shows renal involvement and its histology and Jude. Okay, among that 2039 patients, proteinuria was observed in 80% of those patients. And if we look at the histology in 216 patients, the type 3 nephritis was detected in 16, type 4, 25, type 5, 18. So more than 50% of patients had a severe type of lupus nephritis. Then before that, the IVCY, intravenous injection of the intravenous cyclophosphamide pulse therapy was introduced. Actually, if patient had the type 3 or type 4 nephritis, the prognosis was quite bad. Almost at 15 years, just only that 40% of patients was okay, but the others really had a serious renal insufficiency. But NIH group, Bompas et al. Reported the effectiveness of the IVCY. And this slide shows the effectiveness of IVCY. The long-term IVCY, CY-L, monthly the CY for the CY for the 6 months, followed by the quarterly IVCY for 2 additional years, is significantly more effective than the 6 months IVCY, as you can see here, and the steroid pulse therapy here. So actually, after the IVCY was introduced, it's become a lot easier to treat the patient with the type 3 or type 4 nephritis. But one thing we have to realize is this. Although the IVCY was shown to be very effective, but actually nearly 20% of patients developed renal insufficiency, as you can see here. So therefore, I must say that the IVCY is not a perfect treatment to prevent the renal insufficiency, and the new approaches are required to overcome this problem. So now I want to talk about a new approach to treat the patient. Then first of all, I want to talk about a new immunosuppressant. Well, the mycophenolate mofetil and the misolvin, which was developed in a country, is a selective inhibitors of inosine monophosphate dehydrogenase and of synthesis of GMP from MP in de novo pathway. Then cyclosporin A is tacrolimus, is an inhibitors for the calcineurin, and then suppress T cells function almost specifically. Okay. Among those drugs, as you people know that, now that mycophenolate mofetil was widely used and showed that the effectiveness, almost the same effectiveness as IVCY. Then that's the company, that's Aspreva, tried to show that the efficacy or usefulness of this mycophenolate in the large random cohort trial. And then that trial named ARMUS was performed. But as you know, this trial was failed to show that efficacy or usefulness of mycophenolate mofetil, because the mycophenolate mofetil could show almost the same efficacy with as the IVCY as shown here. But actually, the number of patients who were killed by that, they died after that the treatment mycophenolate mofetil was larger than the number of patients treated with the IVCY. So Aspreva decided to forget about that to get the approval of the FDA. But even that though this trial was failed, but still so many number of clinicians use mycophenolate, and they can realize that the good efficacy of the mycophenolate mofetil. For example, this paper shows that the meta-analysis to show that the efficacy of the mycophenolate mofetil comparing with IVCY. As you can see here, well, I must say that efficacy of mycophenolate mofetil is exactly the same, but even better than that IVCY. But most important issue of this treatment is a very low risk for that adverse event, especially this amenorrhea, the risk for the amenorrhea was 6 times lower than that IVCY. Okay, as you people know that lupus is a childbearing age, disease for childbearing age. So everybody care about the amenorrhea. But actually, well, in terms of the amenorrhea, mycophenolate mofetil is very safe. So, due to that such a benefits of the mycophenolate mofetil, then that EULAR and also the ACR decided to make the new guideline using that mycophenolate mofetil. And then I'm showing this slide is actually that guideline for that lupus nephritis proposed by that ACR. As you can see, we can choose one of them to induce the remission, IVCY, or mycophenolate mofetil. But actually, this guideline strongly recommending to use that mycophenolate mofetil to induce that remission because of that low risk for that adverse event. And not only for that induction of remission, but also if you look at the maintenance therapy, okay, that's mycophenolate mofetil was strongly recommended to use to keep that remission. Well, but actually we have to think about few problems. Well, then mycophenolate mofetil can show that higher efficacy than IVCY if this drug was given to the black people. And even in the Latin people, in the white, almost the same. But there's no significant difference. But there is a tendency that the effectiveness of mycophenolate mofetil was lower than the IVCY if this drug was used to the Asian people. Okay. Well, in Japan, I couldn't use this drug to treat the patients because we don't have approval to use and by the health insurance. But if you have experience to use this mycophenolate mofetil, I want to know that you are an idea. But anyway, the other problem is, as I have mentioned, the mycophenolate mofetil is not superior than that IVCY. They have almost the same efficacy. So as I have mentioned, 20% of patients must have that renal insufficiency, although they have treated with the IVCY. So that means, although we use the mycophenolate mofetil, maybe around 20% of patients must be show that insufficient response. So we need a further study to clarify this issue. Then I want to talk about this. So I mean that we need still new strategy to treat the patient or new approach how to use that conventional drug. Then I want to talk about that. Then first I want to explain about multi-target therapy using the mycophenolate mofetil and the tacrolimus. Well, this was originally reported by Bae in the Chinese group. Well, he tried to compare the efficacy of that multi-target therapy using mycophenolate mofetil and tacrolimus with this IVCY therapy. Then, as you can realize here, at the 9 months, you can see that significantly high percentage of remission was achieved comparing with that cyclophosphamide PARP therapy. Well, then that day after day, that the rate of remission increase like this. And then if we look at that amount of the proteinuria, as you can see that multi-target therapy, which was shown by that red line, indicates that significantly decreased the level of proteinuria comparing with the patient treated with IVCY. So look like the very effective, if we look at such a clinical manifestations. Then bad news is, as I have mentioned, that mycophenolate mofetil is not approved in our country. So Japanese MDs try to use the mizolbin instead of the mycophenolate mofetil. As I have mentioned, they have almost the same pharmacologically, same the mechanism. Okay, so we Japanese clinicians use the mizolbin instead of the mycophenolate mofetil, and some groups show that real nice result using the mizolbin and tacrolimus. Okay, and in our department, we also tested the efficacy of that multi-target therapy using tacrolimus and mizolbin and tacrolimus alone. Okay, upper part, now this part showing that, changing of the proteinuria. Well, the upper part of the patient was treated with the tacrolimus, and this patient was treated with the combination therapy. As you can see, we can see that it significantly decreased level of proteinuria after the treatment with the tacrolimus mesalazine. And if we look at that, complete remission and partial remission ratio, and as you can see that the 12 months where the patient treated with multi-target using tacrolimus and mesalazine showed a significantly higher ratio of complete remission. Well, so we are thinking that the statistically significant difference between the tacrolimus and the multi-target therapy group was observed like this. And well, now we Japanese are using this mesalazine instead of the mycophenolate mofetil. But in fact, we need a random control trial study using large cohort to clarify the usefulness of this multi-target therapy using mycophenolate mofetil and mesalazine. Well, I want to talk about new therapeutic targets for SLE. First of all, I want to talk about the treatment targeting for the innate immunity. Well, recently, there have been several reports, and maybe I must say many reports, to show that the importance of innate immunity to develop autoimmune response in lupus patients, in addition to the adaptive immunology. Then this slide shows a list of the Toll-like receptors, which are playing a quite important role for the innate immunity. In the mammalian animals, well, it has been reported over the 15 different types of Toll-like receptors. Among those, many people were thinking the Toll-like receptor 9, which binds to the CpG motif of DNA mainly from the bacteria, is playing a quite important role to induce autoimmune response. And also Toll-like receptor 7, which binds to the single-strand RNA mainly from the viruses, can induce the autoimmune response in a lupus patient. Well, the idea is like this. When actually mammalian DNAs are usually methylated. So this methylated DNA cannot bind to the self Toll-like receptor 9. But bacterial DNA, CpG motif is not methylated. So therefore, they can bind to the Toll-like receptor 9 and finally can induce the production of pro-inflammatory cytokine. But well, many investigators found that cDNA in the immune complex are not demethylated, and can bind to the Toll-like receptor 9 and finally can induce autoimmune disorders such as the production of anti-double-strand DNA antibodies. Well, this kind of thing can happen really in the lupus patient. How do you think about that? I must say that yes. Well, this slide shows that activated T cells circulating peripheral blood of lupus patient. Well, if we try to use the activated T cells antibodies to proliferating cell nuclear antigen, well, then we can detect such activated cells in about 75 patients. Actually, totally maybe 65% of T cells circulating in that peripheral blood of lupus patient show such kind of activated feature, well, during the disease exacerbation. And then those cells go into the apoptosis. But due to the dysfunction of a macrophage and others, well, those cells finally go into the necrosis and then release their nuclear antigen to the circulating blood. Then we can detect such a extracted antigen to the circulating blood using by that sandwich type ELISA using monoclonal antibodies to PCNA. Then if we use such a system, then it was shown that 65% of patients has such a high level of circulating antigen which was released from that T cells. Well, the PCNA is a DNA binding protein. Okay, PCNA is a 34 kilodalton protein, but binds to so many other different proteins, and together with the DNA, well, then they make the DNA replication apparatus. Such a large molecules are released if the patient has a high disease exacerbation. Okay. Then if the level of the circulating antigens like this increase in their peripheral blood, we can observe the spread of the autoimmune response to the component of those proteins, as you can see here. Okay. Then not only that, well, the DNA fragment in such a protein and DNA complex is not methylated, denaturated, and binds to the Toll-like receptor 9 and induces the production of pro-inflammatory cytokine. This is the idea. And then in addition, not only such a situation, we can observe increased level of expression of Toll-like receptor 9 in the cells in the lupus patient. This was done by one of my student, Nakano. Well, he took the peripheral mononuclear cells and they tested the Toll-like receptor messenger RNA expression. Then as you can see, comparing with the normal and the patient with rheumatoid arthritis, this lupus patient mononuclear cell has a higher message of the Toll-like receptor 9. And if we try to stain those cells, then you can see that not only that the messenger RNA expression, but the molecules itself is highly expressed in the lupus patient. Then he tried to stimulate the Toll-like receptor 9 using recombinant nucleotide, which can specifically bind the Toll-like receptor 9 and give that stimulation to induce that cytokine production. And as you can see, although that this nucleotide was given to the mononuclear cell to the normal people, nothing occurred. But actually, if this was given to the patient with the lupus, as you can see, this is addition of this nucleotide induced that increase the level of anti-double-stranded DNA and also IL-10 production. So therefore, well, this is also related to that hyperimmune response via that Toll-like receptor 9, so that the innate immunity is playing very important role to induce autoimmune response in a lupus patient. So therefore, many investigators trying to control this abnormality of innate immunity. And then, as you know, that antibodies to interferon alpha, cifrarizumab is prepared, and also the ranibizumab is also in the phase 2 trial. And actually, this phase 2 trial have been done in Japan and also the other foreign countries. And but still, that the paper hasn't come yet, so I couldn't show that the exact data for this time. But you will see quite soon that to show that the efficacy of that such kind of antibodies to interferon alpha. Then, if you think about that Nakano's paper, Nakano tried to make that oligonucleotide which stimulate the Toll-like receptor 9, but we can make that oligonucleotide to inhibit the signal transaction via the Toll-like receptor 9. So this type of the oligonucleotide is now prepared, and now in a trial to show that effectiveness in lupus patients. Well, by the way, then additional information concerning innate immunity is actually at the hydroxychloroquine. You people are using the hydroxychloroquine to treat the patient with lupus in your clinic, but maybe. Well, recently it was shown that hydroxychloroquine can inhibit the Toll-like receptor pathway. Well, theory is like this. Well, the hydroxychloroquine binds to the cDNA and like this and inhibit the bind of this DNA to the Toll-like receptor 9. And then, in addition, well, that hydroxychloroquine inhibit that activation of Toll-like receptor 7 and inhibit the signaling via the Toll-like receptor 7. So now that hydroxychloroquine is quite classical drug, but it was really, people now really attending this new type of that drug. I mean, new function of the hydroxychloroquine. It's amazing, But we cannot use hydroxychloroquine the same as mycophenolate mofetil in Japan. That's very bad news. But anyway, then I want to talk about the new therapeutic targets associated with adaptive immunity. First of all, I want to talk about the B-cell pathway targeting agent. Well, this slide shows that the B-cell pathway targeting agent, one of the type of drug is a B-cell depletion, the other inhibition of B-cell activation, and maybe induction of B-cell tolerance. Well, that most representative want to delete the B cell is, of course, the rituximab. And ocrelizumab, ofatumumab, all those drugs were actually antibodies to the CD20. And the epracizumab is an antibody to the CD22. Well, actually, I don't have enough time to talk about all those. Then I pick the 2, 3 of them, and I want to talk about that. Sorry. The first one, I want to talk about rituximab. Well, many investigators versus clinicians experienced that the rituximab is quite effective to treat the patient if that patient resistant for the conventional therapy. So that Genentech and Biogen decided to have the large random control trial named Explorer and Luna trial for the lupus nephritis. But actually, as you know, that this trial failed to show the usefulness of that rituximab because I think that's because of bad design for that trial. They use that not only the severe patient but the very mild patient. So that the design was very bad, maybe. Even after this trial was failed, actually many investigators showed the effectiveness of that rituximab, for example, hemophagocytic lymphohistiocytosis and the autoimmune hemolytic anemia, thrombocytopenia, skin manifestation, or lupus nephritis. Well, as long as we use rituximab to treat the patients who are resistant for that conventional therapy, then that rituximab can show that real nice result. I want to show one of the results using my own patient. Well, this patient was diagnosed as having that proteinuria, having that lupus because of this proteinuria, and that large amount of corticosteroid was, prescribed to treat this proteinuria, and responded, and then the pulse therapy was also performed. But proteinuria improved, but actually this patient started to have that acute confusional state, NPSLE lupus. Then we tried to treat with that IVCY, but acute confusion state get worsened. Then we decided to use the rituximab. Soon after the administration of rituximab, this acute confusional state disappeared, and also that increased level of IL-6 in cerebrospinal fluid, 24 to 4 became that at 7.6. So that amazingly it was effective. Not only this patient, the rituximab sometimes very useful to treat the lupus nephritis. When then this was a new treatment and algorithm, and which was proposed by the ACR. Well, as you can see here, well, although that no evidence for the rituximab, but in this algorithm, rituximab was recommended as a second-line treatment for that vasculitis and lupus, myocarditis, and lupus pulmonary artery hypertension, and also. As you can see that lupus, mononeuritis multiplex, and also the CNS lupus, like our patient, and lupus type 4 nephritis. So, as long as we use the rituximab for the patient who are resistant for the conventional therapy, maybe that drug can show the power, But we need that, maybe evidence to show that the efficacy of rituximab. Well, then I want to talk about that therapy using that CD22. Okay, epracizumab is a humanized IgG1 kappa monoclonal antibody. Well, although that this epracizumab is an antibody to the surface marker of a B lymphocyte, but the epracizumab does not have the cytolytic function like the rituximab, but induces the internalization of CD22, as you can see here, and then can have that immunomodulatory power, immunomodulation, for that B cell. Then this slide shows that the result of phase 2 trial by that Wallace et al. And then as you can see that the data, or if patients are treated with the epracizumab, it was found that those higher dose show that the better response, clinical response for that treatment. Okay. Then if we look at the adverse event, okay, then the adverse event occurred in those different group, almost the same as the placebo group. So this drug is quite tolerable and can show that the favorable result, maybe not strong as a monoclonal antibody, which is used in the treatment for the rheumatoid arthritis. Okay. Then I want to talk about the targeting BAFF and APRIL system. Well, since a long time ago, it was found that we can detect the increased level of BAFF or BRIS in the patient with the Sjogren's syndrome. Our group, Morimoto, shows an increased level in systemic lupus erythematosus, and the Kaneko in our group also showed that increased level of BAFF in the mixed connective tissue disease. Based upon that, such a result by the clinicians, drug company decided to make the drug to control this kind of BAFF and signaling. Then first one was atacicept. Atacicept is a recombinant TACI, which is the decoy receptor for that BRIS. But actually, that random control trial in the atacicept was failed. But belimumab, which is antibodies to this BRIS, showed that we have a successful result in that trial. Well, if the clinician choose the patient who are positive for the anti-nuclear antibody or anti-double-strand DNA antibody, then this belimumab can show that higher response rate comparing with that placebo group. And finally, this drug was approved as a drug to treat the patient with lupus about 3 years ago by FDA. Then, as you can see, that comparing with that control group,